And I would like to now invite the next speaker, and that is Professor Viniyendra Pamecha, who is a fellow of European Board of Surgery in hepatobiliary and pancreatic surgery, currently the professor and head of liver transplant and HPV surgery at the ILBS, New Delhi in India. So over to you, Dr. Pamecha.
Okay, can you hear me?
Yes, we can hear you.
Okay, and you can see my slides as well.
Yes.
Thank you very much, Dr. Akash, and thanks to Professor Subhash Gupta and Dr. Saigal for the kind invitation. So what I'm going to do over the next 15 minutes or so is to talk about early graft dysfunction diagnosis and management. So I'll discuss about the controversy in the definition, then the risk factors, and then how to diagnose and manage this condition. Okay. Okay. So allograft dysfunction, if you start with primary non-function, which is basically the graft doesn't really work, and this happens within 7 days. Its incidence is about 1 to 5%. It is more common in cadaveric setting than live donor liver transplantation. You rarely see a primary non-function in live donor liver transplantation because of the healthy grafts and the way this operation is being done. And then when we come to early graft dysfunction, this is basically defined from day 7 to maybe 3 or 6 months. The incidence is about 10 to 30%, and it is associated with a graft loss of around 10 to 25%. So the mortality is somewhere between 10 to 25% in this group of patients. It is more commonly seen in live donor liver transplantation than cadaveric transplant. And that's because of the partial graft, and the liver has to regenerate and then meet the metabolic demand of the recipient. So because of the size of this graft, that's why it is more common in the live donor liver transplant setting. Late graft dysfunction is defined after maybe after 3 to 6 months. The definition in the literature is not clear about the duration from where to define this particular entities. So why it is important to know this? Because the survival is inferior when we compare it with patient with adequate graft function. There is a prolonged hospital course with which is very resource intensive as well. And it is important to identify early to prevent complication and maybe to decide about retransplantation as well. So these are the definitions which are there in the literature. And these were earlier definitions which were mainly based on levels of ASTs. And that was basically more than 2000 or more than 2500 ALTs within first 7 days of transplant. That was the definition being used for initial poor graft function. Then in 2010, Althoff defined the definition, which was based on bilirubin and INR. That is a bilirubin more than 10 milligram per DL on day 7 or an INR of more than 1.6 on day 7. And they also included the AST component, which is basically more than 2000 within the first 7 post-operative days. So this is the definition which was derived from cadaveric setting. And there's been got a lot of controversy whether this can be used for the live donor setting or not, because the way the graft functions are a bit different in cadaveric and live liver transplant settings. So this is a definition then being validated into live donor liver transplant settings as well. Again, this was done in A2R data, that is the American data, which was used as same bilirubin or INR on day 7. And basically the predictive value of all these other definitions are quite low. Okumara defined it as again day 10, bilirubin of 10 and INR of 1.6 on day 7. Again, the predictive value was low as well. And Ikagami actually had further specified the definition being bilirubin of more than 20 for 7 days after post-operative day 7. And that was very specific actually. It was, and once you have that type of a patient, then the mortality in that group of patient is very high. That is above 90%. We ourselves have tried to define it further, and we thought that there should be dynamicity in the definition in order to exclude all other components of which can lead to early graft dysfunction, because we all know that the early graft dysfunction is an entity where you have to exclude all the other treatable causes. Then only we can come to conclusion that this is primarily because of graft dysfunction. So our definition is basically bilirubin of more than 10 plus INR of more than 1.5 plus a urea of more than 100 for 5 consecutive days after day 7. And we had a very high predictive value of around 98% on this patient. So if you have this type of patient, then the mortality of this patient will be about 90% in spite of all resources being used to prevent it. So this is what it is important, because then you can decide on retransplantation, whether to offer a retransplant or not. And that becomes particularly important in the live donor setting, because of the because the availability of graft will be a very rare in live donor liver transplant setting. So you need to have a very specific definition to define this entity. So what are the risk factors? Early graft dysfunction, if you see, it's a spectrum of things which can cause this. This may be donor related, that is age, BMI, comorbidity, prolonged ICU stay, hemodynamic instability, or if the patient.
Did you have your dinner already?
Sorry, sorry, not yet. I haven't had the dinner yet.
I think you can just ignore that.
Okay, so that was good. So, okay. Am I audible? Am I okay?
Yes. You're very
Yeah.
much audible. Okay.
Oh, I thought it's not that boring that people are worried about dinner.
No. Please go ahead. Please go ahead.
Okay. So you need to then the other things are cause of death. So this is more common with neurological causes of death. So elderly patient with cerebrovascular accident, those donors are at a higher susceptibility of developing early graft dysfunction if you use those. Then obviously donation after cardiac death, marginal donors, and serum sodium as well. Then in graft-related fracture like statosis, steatohepatitis, then the techniques of flush, again, there have been lots of techniques which have evolved over the time. And different techniques have been shown that they can actually cause early graft dysfunction as well. Then recipient, that is the most important. What is the metabolic demand of the recipient? It is a MELD score. Then again, whether it is a group compatible, incompatible, again, comorbid status. If you're transplanting a patient with ALF or ACLF, in particular ACLF, which are very high risk, then again, they are at a high risk of developing early graft dysfunction. Then a previous surgery, previous sepsis, which was being discussed in the previous session, that how sepsis actually can alter the course of events in a particular patient, previous episodes of AKI, sarcopenia, very common in Indian patient actually, because most of them decide late. Again, refractory site is very much common in Indian patients. We need to keep an eye on all those things. Then portal vein thrombosis, post-operative complication. Again, intraoperatively, hemodynamic status, blood loss. If there is a long warm ischemia time, how much time the surgery took, and whether this was a complex reconstruction, and logistics about whether it was a prolonged cold ischemia time, particularly in cadaveric setting. So why I'm enumerating all these factors is whenever you're evaluating a patient, you should keep all this spectrum in the mind, and also for a center to learn that how can we can actually decrease the incidences of this, or not to add multiple factors in order to develop early graft dysfunction. And then coming to partial grafts, that is live donor liver transplantation. The entity initially was thought to be a small for size, but now we have learned that it is a portal hyperperfusion which causes. So it's not exactly GRWR which is related to it. It is actually how much is the portal flow and pressure, and how much is the actual graft weight, which can lead to a small for size syndrome or a small for perfusion syndrome. So just comparing DDLT versus LDLT, in DDLT it is more common because of ischemia perfusion injury and a longer CIT and WIT, and marginal livers are being used more and more. Whereas in LDLT, it is portal hyperperfusion, liver has to degenerate, and also it is technically more complex operation with a more risk of infections as well. So that's where the things are different in terms of development of early graft dysfunction. So it's a spectrum of injury, which can be from mild hepatic dysfunction to just isolated hyperbilirubinemia, or it can lead to a prolonged cholestasis, ascites formation, coagulopathy, leading to septic complication, and which can lead to renal and pulmonary failure. And if this doesn't get better or not timely intervened, then it will lead to a retransplantation or death. So that's the spectrum. And most of the patient actually will be within the spectrum of isolated hyperbilirubinemia associated with sepsis. And most of this will recover over the time, but you need to really treat them very aggressively in order not to develop problems. So coming to how to go about this. So if you've got a patient who is improving, who's hemodynamically stable, his lactate is coming down, acidosis is improving, he's got an adequate urine output, is got an improving INR with decreasing bilirubin, and he's got a normal glucose metabolism with a improving mental status as well. That all means that you've got a healthy graft function and you just continue same management. But if the patient is not showing all those things, signs or some of this, then you need to really check into what the LFT pattern is. If it is predominantly hepatocellular pattern, then and if it is associated with signs of liver failure as well, like prolonged INR, encephalopathy, hypoglycemia, or lactic acidosis, then basically you need to see whether this are improving over the time. Then it is just maybe an ischemia reperfusion injury. If they are static or progressive, then you really need to rule out vascular causes, or you need to really rule out on the AMR side or ACR, which can happen in this. If this liver failure is present, that means it may be a primary non-function, or it may be a vascular causes like hepatic artery thrombosis, portal venous thrombosis, or non-thrombotic infarction or ischemic hepatitis. Obviously, you need to do an urgent imaging, which will be to start with an ultrasound. An ultrasound actually can show you if the vascularity is good, then maybe you need to do a biopsy to rule out all these other causes. If there's biliary dilatation, then you need to do an M.I.C.E, which can be followed by ARCP or PTC, depending on whether they got a cholestatic pattern or not. Then if it is a predominantly cholestatic pattern of liver enzymes, then you need to see whether again they got a signs of liver failure. If they got signs of liver failure, then you need to see whether it is a small bowel syndrome or it is just septic induced cholestatic. If there are no signs of liver failure, then again you need to rule out biliary causes or drug induced injury, which will present as cholestasis, and you have to evaluate accordingly. So how to go about it? So you need to have a thorough clinical assessment. You need to check on the hemodynamics. Where you need to thoroughly check on the in terms of how the clinical status of the patient is. Ascites definitely they will be draining more ascites after the transplant if they are developing early graft dysfunction, whether it is associated with sepsis or not. But they all will actually have increased drain outputs. You need to do regular gas and check on the labs how the progress is happening, and then you have to investigate them with ultrasound Doppler cultures. You need to review, and obviously you need to see the fresh cultures as well. And you always have to maze them with CT scan of chest and abdomen. Chest is important as because there are lots of this patient will actually develop chest related complication as well. CMV you have to always check on, and if you don't find a reason, then you have to biopsy them, and then biomarkers have been developed which can sometimes give you information which direction the patient is going in. And there was discussion about EJD and sepsis. You don't know which comes first, but they do coexist quite a lot of time, and they will impact the outcome of a patient. And basically it is always difficult to say which one came first. But when you have EJD, then the rate of sepsis is very high. This is our own data. So once in the patient who had EJD related mortality, this incidence of severe sepsis was around 85% compared to 33% in the ones who didn't have EJD related mortality. So sepsis is very high in this group of patients. And that's why they have prolonged hospital stay, ICU stay, re-transfer to ICU as well, and the overall morbidity is high as well. So how we can find sepsis early in this group of patients? And there are simple things which can actually predict sepsis, like how the platelets counts are after the transplant. So what we have seen is in patient who doesn't have sepsis, the nadir platelet count will be reached on day 3. The ones who develop sepsis, the nadir platelet count will be on day 5. So if you've got a patient who has got consistent thrombocytopenia, suspect sepsis or a suspect early graft dysfunction in them, and you have to be careful in terms of hiking up immunosuppression there. And you can see that the ones who had continued to remain thrombocytopenic did develop sepsis on day 7 as well. So that's a very good predictor of where the patient is going on. And you can actually modulate your immunosuppression based on how the platelets are behaving after the transplant. And this has been shown in the DDLT setting as well, and ours was in the LDLT setting. Again, thrombocytopenia is associated with early graft dysfunction, and both post-transplant sepsis significantly impact the thrombocytopenia as well. So how to prevent sepsis in this group? I'm not going to go into details of this. Basically, you have to take all the precautions, so minimize immunosuppression, early extubation in order to decrease the chest complication, early removal of drains, then always feed them. Nutrition is most important. We basically start feeding on day one itself. So we'll start with ORS on day one. And if they're tolerating well, then we'll just feed them with the NG and we'll continue until they are getting better. So sometime our patient will be on feed because, for maybe a couple of weeks actually, because most of these Indian patients are very sarcopenic and they need nutritional support. And you need to keep an eye on fluid balances very much. I'll show you how fluid balances are important in this particular group of patients. So coming to immunosuppression, so what we learned over the time is in our group of patients, basically they don't tolerate even in high doses of steroids well. So what we were seeing that the incidence of severe sepsis was very high when we gave them 1 gram of methylpred at reperfusion. So then we slowly decrease it. And then basically now we only give 100 milligrams of methylpred on reperfusion. And what we've seen is the incidence of severe sepsis has come down significantly in this group of patients. When you have got an LDLT graft, there is not much of ischemia reperfusion injury. So you don't need high doses of steroids in the initial postoperative period. You can get away with a minimal immunosuppression, and that helps in preventing sepsis as well. Then it is sometimes actually difficult in live donor setting to differentiate between sepsis and rejection. And sepsis, obviously, you will have signs of fever, tachycardia, tachypnea, rising lactate, altered sensorium. Again, thrombocytopenia and cytopenias are very common with sepsis. And in sepsis-induced cholestasis, it will be an isolated hyperbilirubinemia. The rest of the things will be okay, but the bilirubin will go very high. In rejection, most patients will be clinically well. Fever may be there. There will be higher cytokine output. Their cytopenias will be less common, but there will be raised eosinophils, and there will be doubling of transaminase. Why I'm presenting this is because this happens very common in live donor setting, that when you are going low on immunosuppression, you always think maybe it is rejection, but you have to keep an eye, because once you are low on the immunosuppression, rejection, then you have to pick up the rejection very early on. You can't just let it go. So whenever there is a doubling of transaminase, you need to pick up the immunosuppression very quickly actually. Then vascular causes, again, you need to, these are preventable and correctable causes. And the important thing about vascular causes, if you pick up early at asymptomatic stage, 80 to 100%, there will be salvage rate. If the patient is symptomatic because of a vascular cause, then the salvage rate, graft salvage rate comes down to 50%. So that applies to heart, PVT, and outflow problems as well. So you need to detect early at an asymptomatic stage, and that's why routine Doppler early on in the for maybe twice a day for the first week is important in live donor setting. I'll just skip this bit. Yeah, there was this talk of in the panel discussion, people were talking about the small for size as well. So as I said previously, it's a portal hyperperfusion related injury. And this is just to show our data on that it's not exactly the graft weight. So this is basically 71 patients with less than 0.8 and lots of patients with more than 0.8. So there was no difference in EGD related mortality based on graft weight. But when we come down to less than 0.6, that's when the mortality becomes significant. So it is very smaller graft which are susceptible of portal hyperperfusion injury. So if you got a good outflow, then it is unlikely that you will develop a small fossa syndrome until 0.6 or 0.65. If you go below that, then that's where it becomes a problem. And that's where you need to think about modulating portal flow, which can be done with a portocaval shunt or a splenectomy or a snake artery ligation, which will decrease the portal flow and improve the liver regeneration. So there are risks associated with this, which is portal hypoperfusion, portal vein thrombosis, sepsis, and encephalopathy. So these are some of the criteria which have been laid down about when to do a graft inflow modulation. It's based on pressure or flow or a gradient. I think gradient is more important rather than absolute values, because of how is your CVP will determine how your portal flow is going to be after the operation. And that's an important parameter to take in whether when you want to do portal inflow modulation. In post-operative period, if you have that entity, then maybe splenic artery embolization can help. There is some data on that, but I'm not sure because there is always risk of splenic abscess development and the development of sepsis, and whether you will be able to salvage the patient or not. I'm not 100% sure, but it is worth considering in a particular group of patients. Again, coming to fluid management, that how in small graft, if you're not looking after your in the ICU properly, can become actually in a small for science syndrome. So if you've got an overloaded patient with a high CVP, that will actually reflect onto your develop as a functional congestion, and it will develop it will reflect on your portal flow as well. And this we have shown that the CVP actually correlates with end PVP pressures. So a high CVP will actually correlate with the portal pressure after the reperfusion once the graft has gone in. And this actually will lead to higher AST, ALTs and high lactate values as well. And this will translate into higher development of early graft dysfunction as well. So you need to keep a very close eye on your fluid balances, should not overload the patient as well. And the cutoff for the CVP is around 10. So you should not let your CVP go above 10. So if you don't do volume resuscitation, use more ionotropes than volume resuscitation when the patient is unwell. And this is some of the work which we have done to prevent early graft dysfunction. This was a randomized controlled trial on arterial perfusion on bench. And we've shown that if we do this, then the early graft dysfunction decreases in LDLT. So this is my last slide.
Wrap it up quickly.
Yeah, this is last slide. This is last slide. So management, you need close monitoring. You have to have a hemodynamic monitoring in terms of flow track and everything in order to see what your cardiac output is, what your SVR is, in order to assess the fluid requirement and according to titrate them. Then again, ventilatory support. If the patient is in encephalopathy, don't wait long, just tube them early on. And if they're not in encephalopathy, you need to give them good NIV support in order not to develop chest sepsis. Fluid balances, as I already said, nutrition I already covered. Then prevention of sepsis and reduce immunosuppression. Always you have to treat the modifiable factors. The list is there. This all need to be aggressively looked into and treated before you come down to the definition of early graft dysfunction. The role of plasmapheresis, I would think there was some discussion in the panel discussion as well. There can be a role, there can be a patient where plasmapheresis should be considered if it is not septic. So if they are blood culture negative and though no source of sepsis, then bringing down bilirubin actually might help the patient as well. CRRT, if the ammonias are very high, then again CRRT may be helpful. And then again, if nothing is working, then you really need to look into retransplantation. And the big question is whom to retransplant and how to identify those patients. That's where our definition can help people in identifying those group of patients. So early allograft dysfunction is common multifactorial entity, more common with duodenal liver transplantation. And ideal definition is elusive. Then you should keep an open mind when you're evaluating this type of patient. Prevention is always better. Avoid, basically should not have a second hit. So when you got factors, you know that they're going to lead to early graft dysfunction, then you need to monitor the patient and manage them in a way that they don't develop second hit like hypertension, hypoxia. They all need to be taken care of in order to avoid a second hit. Then early detection is key, and all the modifying factors should be aggressively treated. And with good supportive treatment, majority will recover, but there will be a proportion of patients who will develop graft loss and need retransplantation, and identifying this is key. Thank you very much. Thanks a lot.
Thank you, Dr. Pamecha. We can now invite questions. And I think Naveen wants to ask one question.
I'll read out the question on his behalf.
I think so.
Has the decreasing of induction steroids increased graft dysfunction? He brought this up because of the discussion with Professor Rela in the last after the last talk, where he mentioned that induction steroids are mainly for preventing inflammatory cytokine storm. So your comments, please.
Yeah, so the answer is already, you've already answered my question. So the steroids are to decrease the inflammatory cytokines, and this is what happens with the IR injury, which happens with the cadaveric liver grafts. In live donor liver transplantation, that doesn't really happen. There is not much of ischemia reperfusion injury. So you can get away from giving high doses of immunosuppression to start with. And then you can always monitor the patient which way he is going, and then you can decide whether you want to give, optimize the immunosuppression over the course of the next few days. So the problem with our patient is basically, if you give them high doses of immunosuppression to start with, then you've gone onto a irreversible road, and it's difficult to come back. Okay, and once you're making them susceptible to severe sepsis, and then some of this patient, then you will lose out because of severe sepsis. On the immunosuppression side, you always have the opportunity to hike it up and then optimize it. But once a patient goes into severe sepsis, then it's very difficult. They're very difficult to manage.
Thank you very much.
That's why our policy.
I think we have exceeded time, and organizers are getting restless about the next session. I see my co-chairperson, Dr. Vikram Raut, is on line. I'll request you to close the session, please.